Good morning. I'd like to start by telling you a story about a patient whom I actually saw. He was referred to me for a second opinion regarding whether or not he should have a bypass operation. Briefly, he was 55 years old. He had stable angina. His symptoms were well controlled with medications. He was referred by his doctor for an exercise test, which showed normal findings. He had an exercise capacity of 8 METs, which is normal for his age and gender. He had no EKG changes, no angina, no arrhythmias, and no symptoms. So at this point, it would have been perfectly reasonable to treat him with medical therapy, and even by today's standards of care, that would be okay. But at the time that the doctor referred him for an exercise test, he also obtained a SPECT imaging study. And that SPECT imaging study would have looked something like this. Showing a reasonably large area of anterior ischemia. Well, when his doctors saw this, they couldn't ignore it, so it led to a whole series of events. He underwent a heart catheterization. He was then referred to a surgeon and was scheduled for bypass surgery. And at this point, the patient called a timeout and decided that he wanted to have a second opinion. So he came to see me. And I looked at his history and his films and the results of his SPECT scan. I discussed this with a number of my colleagues, and to make a very long story short, we decided to go ahead and recommend a bypass operation as well. Now, he had the operation, and the operation went well, except for one thing, which is that he developed a very serious life-threatening sternal wound infection after the operation. It took about a year and multiple plastic surgery repair procedures until this problem finally resolved. Well, at the end of the year, the patient came to see me, and he said, this is now after like the worst year of his life, and he says to me, "Dr. Lauer, tell me, was that bypass operation really necessary?" And as I was thinking about it, what occurred to me was that perhaps he was asking the wrong question. The question should have been, "Dr. Lauer, was that SPECT imaging study really necessary?" Because it was the SPECT imaging study that led to a cascade of events that ultimately, you might say, caused his sternal wound infection. Okay, now that story ends well in the end, although there was a very bumpy road. Here's a story that didn't end so well. This was a 52-year-old woman reported in Archives of Internal Medicine. She had hypertension, she was overweight, she presented with highly atypical chest pain. She had no real risk factors for disease except for her hypertension. Her hs-CRP was normal, her lipids were normal, and it would have been perfectly reasonable at this point to leave it at a diagnosis of musculoskeletal pain, for which she did have symptoms that were suggestive. Just leave it at that. But her doctor, just to be sure, decided to send her for a CT angiogram. And the CT angiogram would have looked something like what you see here. It showed a moderate-sized lesion that was calcified in the LAD. So then, when her doctor saw this, this then triggered an invasive angiogram. And unfortunately, when the invasive angiogram was done, the catheter, upon entering the left main coronary artery, dissected the wall of the artery. This then led to a massive dissection, which then led to a massive and imminently life-threatening myocardial infarction. She went through some rather heroic therapy. She was saved, but was left with severe heart failure. And in fact, her heart failure was so severe that within a few months, she was put on the list for a heart transplant, and she wound up getting a heart transplant. It's one of these real horror stories, but here's an example of an imaging test that was probably not necessary, for which the pretest likelihood of disease was exceedingly low. And unfortunately, this led to a cascade of nearly catastrophic events. Okay, so those are two clinical stories. Now I'm going to tell you an academic story. So back in 1998, my colleagues and I were very proud to publish a paper in Lancet. We looked at the practice of routine stress nuclear imaging testing among asymptomatic patients who had had prior coronary bypass surgery. So we looked at a very large number of patients who were followed over time, and what we found was that those patients who had evidence of ischemia were at increased risk for having major coronary events. And on the basis of this, we then came up with a proposed treatment algorithm. And that's shown in this slide. And to be honest, this treatment algorithm was an educated guess. And what one would do is take a patient who had prior bypass surgery, was asymptomatic, had no angina. You would refer them for an exercise test, look at the exercise test result, then look at the nuclear imaging result, and on the basis of that come up with a potential treatment plan. And on the basis of this algorithm, in 3 out of the 4 arms that a patient could go to, we were actually recommending that either invasive angiography be considered or that it would actually be done. So this idea that there should be a downstream procedure that would follow from a diagnostic imaging test is not an accident. It is something that even we, within the context of an academic publication, explicitly recommended. So when we think about downstream procedures, we can think about 2 kinds. I'm going to talk about what I'll call problematic downstream procedures, and then I'm going to talk about incidentalomas. So a problematic downstream procedure would be one in which a patient is being evaluated for a particular problem. The imaging study shows something which is related to that problem. The doctor and the patient respond in a way that seems to make a lot of sense in the context of that problem, but may ultimately lead to unneeded procedures. So here's an example of an interesting case, because this case is particularly interesting because we actually have a built-in control. It's not a randomized trial, but there is a built-in control. So in this study, which was published a couple of years ago, investigators, an international group of investigators, looked at the case of a health screening program in which the healthcare system decided to offer CT angiography as part of screening for coronary artery disease. Now, all the patients had a standard workup, including measurement of blood pressure and cholesterol, assessment for diabetes and smoking. But in this case, there were 1,000 patients who went on to have a CT angiogram, and there were another 1,000 patients who did not have a CT angiogram, and these were considered to be matched controls. Now what happened was about 20% of these patients wound up having, of the patients who underwent CT angiograms had evidence of coronary artery disease. And then a small but nonetheless real proportion of those patients then went on to have secondary procedures, a variety of secondary procedures, including other imaging tests as well as invasive imaging tests. Patients who had initially undergone a CT angiogram were much more likely to undergo a subsequent procedure than those patients who did not undergo a CT angiogram. And although the numbers are very small, what's particularly striking are the number of revascularizations. Those patients who underwent CT angiogram, about 1% of them wound up undergoing a revascularization. Remember, these patients are totally asymptomatic to begin with. And only 0.1% of one patient of those who did not undergo a CT angiogram wound up undergoing a revascularization later on down the line. And the investigators said something very interesting. They talked about evidence-free procedures leading to more evidence-free procedures, and they point out that it is exceedingly important to consider the pretest probability of disease. Now, it's a fundamental Bayesian truth that if the pretest probability of disease is low, that any positive finding is much more likely than not to be a false positive finding. And yet we have to be aware of the fact that these people now are particularly vulnerable for undergoing downstream procedures, which could be invasive or even harmful. An interesting perspective on this was brought by Dr. Stone in the New England Journal in 2006, and he talked about a different kind of problem, which he referred to as the incidentaloma. I'm sure you've all heard about this. Here is a situation where there's a finding on an imaging test which is unrelated to why the test was ordered in the first place. And therefore, the pretest probability of diseases is really low. It's even lower than, say, the health screening program that we just looked at. So he told the story of about an elderly man who he had thought he had diagnosed with temporal arteritis, but as part of the workup for his unexplained fevers and his high sed rate, he underwent an abdominal CT. Now, mind you, at the point that this abdominal CT had been done, he already had a temporal artery biopsy, which demonstrated that he had temporal arteritis. Well, the CT scan showed a renal mass, and this then led to a whole cascade of events and consultations for what turned out to be nothing. And he says something interesting in his perspective. He talked about the fact that at this point in time there seems to be a little quantification of the economic and clinical impact of incidental findings. He notes that both the NIH and industry are pouring a lot of money into developing imaging procedures, making imaging procedures more exquisite, more sensitive, and this almost certainly is going to lead to a greater problem with incidentalomas. He points out that any discussion about incidentalomas has to include the specter and risk of medical malpractice, and I know this from my own personal experience, but physicians are often taken to task by lawyers for failing to act on early evidence of disease when the vast majority of such cases acting by the physician would lead to no real benefit. And then he bemoans the use of certain terms that frequently appear on imaging reports, like cannot exclude, or consistent with, or need to rule out, or suggest some kind of follow-up exam. Well, there was a quantification of incidental findings, and this came a number of years later, and this is in a particularly interesting study. This was a study that was done at Mayo Clinic, looking at incidental findings among patients who are undergoing imaging solely for research purposes. So you might say these are truly incidental findings because even prospectively, the doctor had no intention of getting the imaging study for the purpose of clinical care. So they looked at about 1,426 research imaging studies that were done at the Mayo Clinic. And it was amazing. About 40% of these patients had at least one incidental finding. And on average, there were 2 incidental findings per patient. Now, a small number, about 6%, underwent some kind of significant clinical action. That could have been a follow-up test. In a few cases, there appeared to be a benefit. In a few cases, there appeared to be harm. And in the vast majority of these cases where subsequent clinical action happened, an expert panel was unable to figure out whether or not there was any benefit or not. And it turns out that the big offenders, that the kinds of tests that seem to lead to the most number of downstream studies, are CT scans of the chest and the abdomen, MRI of the head, and then to a lesser extent other kinds of CTs and plain films. And here are a couple of examples. In the upper left-hand corner is an 85-year-old woman who was found to have a renal mass that probably turned out to be a renal cell carcinoma, and so she might have benefited from this. The upper right-hand corner shows is a 56-year-old woman who was undergoing this CT scan for unrelated purposes, and she had these masses there, and these just turned out upon subsequent invasive investigation to be hyperplastic lymph nodes. And then in the bottom right-hand corner, we have a case of a 31-year-old woman who was undergoing a head MRI for obsessive compulsive disorder research. She had this cyst-like structure there that turned out to be a grade 2 ependymoma. So what's the problem here? Well, the problem here is something called overdiagnosis, and this is something I'm going to actually talk about a little bit more in the next lecture. Overdiagnosis has also been referred to as pseudo-disease or non-disease. And overdiagnosis refers to the detection of some kind of what we'll call an abnormality, but this is an abnormality which, if we had left it alone, never would have caused any problem. Now, it's a difficult definition for people to get their hands on because it fundamentally is a counterfactual. If we didn't know this, we can say that nothing would have happened. And as we're becoming more sophisticated about the nature of disease, ranging from atherosclerosis to cancer, we're coming to realize that many cases of quote-unquote disease are really not disease at all. They don't progress, or they progress so slowly that some other problem winds up taking over. Or in some cases, there may actually be spontaneous regression. Problem is that you don't know that in advance, and so you may be tempted to go ahead and treat this or work this up further. Treatment is not going to help because this non-disease or pseudo-disease was never going to cause a problem in the first place. But the risk of harm is still very much there. And one example that I remember very well from my days of training was mitral valve prolapse in young women. There have been some literature suggesting that a little bit of prolapse seen on an echocardiogram seemed to correlate with anxiety in young women. And so we started to routinely evaluate young women for mitral valve prolapse. And I remember women in my practice telling me about how they were suffering from this horrible heart condition, and all it really was overdiagnosis on an echocardiogram. Overdiagnosis is a hot topic, and for those of you who are interested in learning more about this, I'd strongly recommend you look at Gilbert Welch's book that came out last year. He argues that overdiagnosis is one of the major public health problems that we're facing. That it has had a staggering impact on millions of people. It has added huge costs to the system. And as I'll talk about in the next lecture, there are a number of factors that are creating cycles of more and more and more overdiagnosis. And these factors, including financial gain and belief and media and self-reinforcing cycles, which I'm going to outline, these are making it very difficult to solve this problem of overdiagnosis. Now, overdiagnosis has attracted attention. Some of you may be aware of the American Board of Internal Medicine and other groups have set up a so-called Choosing Wisely campaign, and they have identified various procedures which they will admit are being done too often, and they're encouraging doctors and patients to get into conversations about ways to reduce them. And I show you here the procedures related to my field, to cardiology. And what's interesting is they're all imaging. Don't perform cardiac stress imaging in people who don't have symptoms. Don't perform it as part of routine follow-up in asymptomatic patients. Don't perform imaging in people who are scheduled to undergo low-risk surgery, and don't perform echocardiography for asymptomatic or mild valve disease as part of routine follow-up. So I think it's particularly striking that essentially all of the items that the cardiologists have identified as being cases where we need to choose more wisely are imaging studies. So let me end by suggesting a thought. Let's remember that tests ultimately beget tests. Sometimes that's a good thing, but often it is not. Downstream procedures can be divided into two types: those that are linked to the suspected diagnosis. I call those problematic downstream procedures, and that's a real problem when we're dealing with patients in whom the pretest likelihood of disease is low. And then incidental findings, where the finding is totally unrelated to why the patient was referred for testing in the first place. It's hard to quantify the downstream procedures, but we probably should focus on low probability populations, recognize that the fundamental problem is overdiagnosis, and I think we have to come to grips with the idea that this problem of overdiagnosis is getting worse, and that leads very nicely into the next lecture. Thank you very much.